In this video, I will talk about syndrome of apparent mineralocorticoid excess. We know that principal mineralocorticoid is aldosterone. In this syndrome, the aldosterone level is not increased, but there is an apparent mineralocorticoid excess activity. We will find out how that happens. We know that adrenal gland, mainly adrenal cortex, has three layers: zona glomerulosa, zona fasciculata, and zona reticularis. In the zona glomerulosa produces mineralocorticoid, mainly aldosterone, and zona fasciculata produces cortisol. This cortisol has both glucocorticoid and mineralocorticoid activity. We know this cortisol is converted into cortisone by an enzyme that is produced in the kidney. The name of the enzyme is 11-beta hydroxysteroid dehydrogenase type 2, which converts this cortisol into cortisone. But in this syndrome, there is a defect of this enzyme, of this 11-beta hydroxysteroid dehydrogenase type 2. As a result, this cortisol cannot be converted into cortisone. So this cortisol binds with mineralocorticoid receptor and it shows the features of mineralocorticoid. So this cortisol shows the features of aldosterone, though the aldosterone level is not increased. That's why this syndrome is known as apparent mineralocorticoid excess. Due to high activity of mineralocorticoid, there will be feature like high sodium and high water. So the patient of this syndrome will show the features like hypertension. Also, due to high mineralocorticoid activity, the potassium will be lost. As a result, there will be hypokalemia, and hydrogen will follow this potassium. So there will be metabolic alkalosis. So the typical presentation of this syndrome will be hypertension, hypokalemia, and metabolic alkalosis. One important DD of this syndrome, and that is very high for exam, is Liddell's. So Liddell's syndrome actually shows the same features like this syndrome of apparent mineralocorticoid excess. So the treatment of this syndrome is by using potassium sparing diuretics like spironolactone, or we can also use the exogenous steroid. Why exogenous steroid? Because we know that when we give steroid exogenously, it inhibits the activity of cortisol. So this exogenous steroid will inhibit the activity of cortisol, resulting in resolution of the syndrome. This syndrome is an autosomal recessive condition where there is a defect of this 11-beta hydroxysteroid dehydrogenase type 2 enzyme, or it can be acquired by consumption of licorice. In licorice, there is an acid that is glycyrrhetinic acid, which blocks the activity of this enzyme, resulting in syndrome of apparent mineralocorticoid excess.